Hi, I'm Vivek Agrawal. I specialize in shoulder surgery and sports medicine here at Lovelace Westside Hospital. I always appreciate the opportunity to talk about advances in shoulder surgery, and hopefully you'll find something here that will be helpful for your patients as well. So I'd like to discuss briefly how I go about evaluating a patient with shoulder pain and then the role that the shoulder girdle plays as part of the overall kinetic chain. We'll certainly hit some of the most common causes and sources for shoulder pain and debility beyond the typical rotator cuff tear. In my practice, and I've been in practice 21 years, specializing mostly in shoulder surgery and sports medicine, and many of these patients that are referred to us for second opinions or previously failed surgeries end up having shoulder pain that's really referred pain, and that can come from cervical pathology, certainly other more esoteric areas as well. Something that really the last 10 years I've come to appreciate much more is the contribution of the brachial plexus and thoracic outlet to shoulder pain. Another often overlooked source of shoulder pain is the suprascapular nerve. This has really come to light, especially in the last 15 to 20 years. I've had a lot of chiropractic referrals over the years, and interestingly, a lot of chiropractors are much more in tune with the suprascapular nerve being a source of shoulder pain. Certainly, impingement is a term that gets tossed around quite a bit, and we'll touch on that a little bit. And there is this idea of coming to the point of making the diagnosis of impingement, but then is it functional versus intrinsic, and really want to drill down. Biceps is another very common diagnosis, and we'll kind of talk about how often the biceps is the primary generator of shoulder pain. Frozen shoulder is certainly can be the great masquerader. It is one of the more painful things we see, and it can coexist with lots of other shoulder pathology. We'll discuss the value of the circle concept for shoulder pathology, talk about rotator cuff, unstable shoulder, discuss the value of improving healing rates for rotator cuff tears. I'll certainly be happy to share with you my personal approach to rotator cuff repairs and how that's changed over the years. And we'll talk about identifying the sources of instability, all of the anatomic sources. I'll again illustrate my personal approach to addressing each of these areas of instability. So, the first I'm always asked is, isn't open repair better? And I happen to be fortunate enough to come along at a time where shoulder surgery was the new frontier, and so much was possible. When I trained in the 90s, really very few things were possible in the shoulder. In fact, pretty much the only thing that was possible was really an acromioplasty, maybe a simple repair through the arthroscope. And after I finished my fellowship, I hardly did anything in an open fashion for the shoulder. So one thing I like about this slide is everything you see on this slide, including the rotator cuff, the labrum, the capsule, even the bone, is all something that can now be addressed effectively in a very minimally invasive fashion. So one great advantage of arthroscopy is that it allows global evaluation and treatment and a lot of flexibility, so we don't have to make a lot of big incisions to get to that point. We have the ability now to identify and treat a broad array of coexistent pathology, and the modern techniques offer excellent results, so much so that for me, I feel like I do a much better job for all of these things with our arthroscopic techniques than I think is possible open. Certainly, it's a lot less morbidity for patients, and every study that looks at what patients would prefer, given the outcomes being equal, they always would prefer an arthroscopic approach. I like this slide because it really helps remind us that the shoulder really falls along the kinetic chain. And by that I mean that so often I'll see a patient that's complaining of shoulder pain. If it's an athlete, for example, let's say they had an ACL tear or a back injury last year, and really this wasn't recognized that this shortens the ground reaction force of the kinetic chain, so they were overcompensating with their shoulder, and then this year ended up with a shoulder problem. It also goes the other way. Many studies show that pitchers that have an elbow problem, many of them actually have subtle, undiagnosed posterior instability at the shoulder, and that's putting more stress, and so now you end up with a UCL tear. So it's important to kind of keep the whole patient in mind and not just focus on the shoulder pain. Every new patient that I see, I get cervical and shoulder radiographs. There's so much overlap. There's so much referred pain from neurogenic sources, and so often people really have poor insight into the fact that there is a connection, or that their pain, whether it's in their hand or elbow or shoulder, may actually be neuropathic or neurogenic pain. I think most patients feel that nerve pain has to have that electric quality where it's shooting over like lightning. They don't really recognize that all pain that we feel is really the sensory component of a nerve. And so even after detailed questioning in the exam where we find that people really have a lot of pain, sometimes they'll try to minimize it. I think we're all storytellers, and we're smart, and we try to come up with a story to explain what we're feeling. And so a lot of times when I'll tell people, wow, you've got a ton of pain that's coming from this cervical level, they'll say, well, I already always carry stress in my neck, or I always carry stress in my shoulders, shoulder blade, so I just thought that was it, that it really didn't have anything to do with the fact that my shoulder is hurting. You see this rich network of nerves that go right by the shoulder, and one of the rules is that if a nerve goes by a joint, it typically will send off some sensory innervation to that joint. So I really pride myself on trying to get the diagnosis right first. I've always told patients and other physicians and providers that it's always better to get a second, third, or fourth opinion or an independent medical evaluation. In the long run, this will save cost, time, and really the morbidity of a failed surgery. Nothing's more expensive than a failed operation. I really try to stay away from latching on to popular diagnoses. I guess I've been in practice long enough now, over 3 decades, that we see that as in orthopedics, there seems to be a popular diagnosis every decade. Impingement was a big one in the 90s. I still hear it quite a bit. Many patients really feel like they were told that there's a spur growing, and if they don't have an operation, it's going to be like a keel of a boat and just cut into their rotator cuff and destroy their shoulder. Biceps has really been something that was very popular after the millennium. We still see it as a popular source where many surgeons are performing isolated biceps tenodesis. And it might interest you to know that in my whole 21 years primarily doing shoulders, I've never performed an isolated biceps tenodesis. I think it's important to get used to really being familiar with the anatomy and the diagnostic imaging for any area we treat. So for the shoulder, I really pride myself on reading all of the imaging myself for CTs and MRIs. Certainly, when it comes to surgery, it's been said before that really the surgeon is the method. So many times patients will come in asking for a specific technique because they feel like that technique is really better. And ultimately, all the results, it can be the exact same technique and have very different results in different hands. And so it's important to kind of drill down and figure out what the right diagnosis is, and then figure out what's the best technique for that particular patient in that instance. So again, Failed surgery can be expensive, so we try to really get it right the first time. There certainly are different options for the same diagnosis. For instance, rotator cuff issues, rotator cuff tears can be grafted. We'll talk about that a little bit. Superior capsular reconstruction is something that's newer and an extension of the grafting. Glenoid bone grafting, which now can be done arthroscopically and really reduce instability rates. So one of the first things that people always ask about is, what are the indications for an acromioplasty? And if we think about it, the acromioplasty, or the idea that we're going to grind down this spur on the undersurface of the acromion, and that's going to help avoid shoulder pain, predates the advent of MRI and CT. So if we look at an X-ray, that spur really represents ossification of this CA ligament. It's not bone that's sticking out in space. And as more time has passed, people have realized that this CA ligament has come to be appreciated as an important structure in completing the sagittal circle and limiting superior migration of the humerus. So I'm of the school of thought that CA ligament should be preserved as much as possible. So here's an example of an acromioplasty where you're seeing upside down a straight instrument on the undersurface of the acromion, and then when we smooth that undersurface, we convert that to more of a flat space. One technical tip I'll point out to you is that I only peel back the CA ligament on the undersurface of the acromion. You see that the entire attachment of the ligament in the front, we maintain that. So yes, there are specific indications where we may perform an acromioplasty, but as a routine treatment for shoulder pain, there's increasing evidence from around the world that there's no clinical benefit to the acromioplasty as a standalone procedure. And it might be interesting that in the United States, most insurance companies will no longer pay for this as a standalone procedure. So we talked about impingement. Certainly, a lot of times people think of the acromial spur as really the instigator of impingement, as extrinsic impingement, and really, as more time has passed, we've all come to appreciate that it's the rare patient that truly has extrinsic impingement from some congenitally narrow subacromial space, or a severe anatomic abnormality with this type 3 acromion or a hooked acromion. Most people have impingement really based on an alteration in the scapula sequencing and neuromuscular control of the shoulder girdle. And so that's where it's really important to figure out how come the shoulder blade isn't moving correctly. Is it the fact that the person's thoracic spine is kyphotic and they're tilting forward so much that it's making everything tilt forward and reducing their functional range of motion? The pectoralis minor, which you saw highlighted in that last disc, has also come to be appreciated as a significant source of shoulder pain and creating functional impingement. When that muscle, which is peeled back here, is tight, it restricts the normal sequencing of rotation of the scapula, of it getting out of the way, especially as the shoulder goes up. The second thing that pectoralis minor is involved in is that it's the third potential space as the brachial plexus and great vessels travel from central out to the periphery into the arm, that can potentially be the source of symptoms and tightness. These other spaces are certainly the interscaling space where you can have a cervical rib or hypertrophic muscles that reduce that potential space. The second space is really at the first rib and behind the clavicle. Many of the clavicle fractures that are referred to me are people who end up having neurogenic symptoms because the clavicle has displaced enough where that retroclavicular space is impinging either on the vessels or the nerves, and that is an indication to fix it. Certainly, as time's gone on, we're able to perform an arthroscopic pectoralis minor tenotomy, and that's become a really valuable option for me for many of these patients who have a lot of symptoms referable to the pectoralis minor, as this is obviously a much smaller procedure than having the patient move forward with something like a first rib resection or referral to a thoracic outlet tertiary care referral center. So a lot of times, unless it's really clear that the first rib area is the primary symptom generator, many patients can benefit from a pectoralis minor tenotomy first. Another area we talked about is the suprascapular nerve. Sometimes in 5 to 12% of patients, this area where the nerve travels through the suprascapular fossa, that superior transverse ligament of the scapula, can be ossified. And that's with most cadaveric studies find that 5 to 12% of the population has a ossified ligament. The thought is that no one is born with an ossified ligament, that this happens sometime during development. And we described a technique for arthroscopic decompression of a bony suprascapular foramen, as for whatever reason I was seeing a lot of referred patients with difficult to diagnose shoulder pain, and then when we would decompress the suprascapular nerve, we were seeing a lot of these, and so we ended up describing that. So here's an example of a ossified transverse scapular ligament, and you can see to the top left where that's a bony arch. The other ones show a more typical instance where we've decompressed it. We talked about the biceps. Originally, when I first started in practice around 2000, a slap repair where this labrum was torn at the top was stitched down, and the thought was that that should do it. We started to recognize that there were some problems with this methodology of always just putting this anatomy back, even far earlier than 2012. I stopped doing just a slap repair by itself around 2006. I had a couple of patients. One was a bodybuilder where we felt like we'd done a really good repair, but he really struggled for the whole year, and ultimately when we went back in, the labrum had healed, but this intra-articular portion of the biceps, which we know has an area of poor blood supply, was really scarred and had expanded, and we ended up doing a secondary tenodesis. And so from then on, we really learned that there is an area of the biceps that just doesn't heal well, and it's better to separate these two so that you don't have a chance of recurrence, but then it also removes that issue as a source of pain. And so Dr. Preventure looked these up as well, and they saw a nearly 40% revision rate for these sorts of patients. And so in this case of a slap lesion, my personal protocol is to perform the labrum repair and a biceps tenodesis to separate these two, which you can see in this upper right-hand corner. We talked about the frozen shoulder. Obviously, lots of people can have this as an isolated diagnosis, especially with patients that have other endocrine disorders such as diabetes. We also see this concurrently with lots of other diagnoses. For example, we know that if a patient has a rotator cuff tear and a frozen shoulder, because this is so intimately connected with the deep surface of the rotator cuff, that stiffness really increases tension and stress at the rotator cuff repair. So if it's not recognized, that can be a source of failure, especially in this posterior inferior quadrant of the joint. And so this is something that we perform a very thorough evaluation of the joint, and if we're going to be doing a rotator cuff repair or some other procedure, it's very important to make sure that there isn't stiffness here, because that can limit the excursion of the rotator cuff, and as we said, be a source for failure and persistent pain. Even for primary frozen shoulder, I don't do any manipulation. There certainly can be catastrophic injuries, and I've seen some of these as referred patients where someone will have a axillary nerve injury or they'll tear something. And so my preference has always been to do this arthroscopic capsulotomy. I feel like I can look at exactly the tissue that's involved, be very selective and minimally invasive in releasing the tissue that needs to be released, so that I can feel comfortable that the patient can move on with therapy, knowing that there isn't going to be some barrier or that we haven't torn something that's normal tissue. The next part of the rotator cuff, even though the subscapularis is the largest member of the rotator cuff family, it's kind of hidden because it's in the front. It's difficult to see for many surgeons arthroscopically, so they don't think about it. But in my own practice, I would say having so much second opinion and referral practices, I'd say that almost half the rotator cuff repairs I've performed over my career also involve some type of repair for the subscapularis. Here's an MRI that kind of shows the biceps that's perched, and anytime we see a perched biceps or it's dislocated medially, that is pathognomonic for having some level of rotator cuff pathology of the subscapularis, and here you can see the tendon is torn. Here is an arthroscopic view where this is the bare footprint of the lesser tuberosity, and you can see the subscapularis is retracted away. And here we've done a transosseous repair, and you see how much thicker the tendon looks when it's put back in its native footprint. Most of the studies will show that up to a third of cases have a concurrent subscapularis tear. So just talking about rotator cuff repairs by themselves, we know that techniques and outcomes and results vary greatly. Failure rates for rotator cuff repair have been reported as low as 11%, as high as 94%. And certainly there are lots of factors to this. Strength and function is certainly better in patients who have a healed repair in the long term. We published a study looking at patients up to 10 years. Others have published studies out to 20 years of patients who've had rotator cuff repairs, and the patients whose repairs healed in the long term always have better strength scores and functional scores. So this is really important, especially when we look at patients who have a large, massive, or say previously operated rotator cuff, that we want to improve our healing rate as high as possible. Here's an example of a massive cuff. We're looking down into the joint, and you can see almost the entire head has been denuded with this massive tear. So, as I'm sure we all know, with increasing level of activity, even as we age, the number of rotator cuff repairs being performed have continued to increase. And certainly if many of these are failing, the cost for the patient, not even thinking about societal costs, are really high. So as the previous slide mentioned, there are several factors. One of the factors in rotator cuff repair failure or success is certainly the surgeon. The surgeon is the method. Many of these arthroscopic repair techniques have a steep learning curve, and because as residents or fellows, there isn't one gold standard way of repairing things. Often surgeons end up performing the technique that their fellowship director or their preceptor in residency did, and that doesn't always end up being the most successful technique. Here's another example of a really large tear where you can see the biceps, and everything back from the biceps is torn and retracted back to the level of the glenoid. Patient factors certainly play a big role. There are some changeable factors and some unchangeable factors. One of the most changeable factors really is smoking. We all know that smoking compromises the small blood vessels first. It certainly has been shown to have a real effect on wound healing and tissue healing. Age of patient, age of tear, the size of the tear, the quality of the tissue, the quality of the footprint. For instance, here you can see this patient has a large cyst right where the rotator cuff needs to heal, so that can affect the healing rate. Other comorbidities such as diabetes, obesity, other medical comorbidities like hyperlipidemia, and again, patient compliance. This is probably one of the most overlooked things, in a sense that we don't really always get buy-in from a patient who recognizes that it takes months for something to heal. So people are really more worried about that day of surgery. But we spend a lot of time really trying to get buy-in from patients to recognize that, look, this thing is going to heal, and it's going to take 3 to 6 months to heal, which is why when you look at the studies, most of the failures are happening in that first 3 to 6 months, because people start to feel good and they really try to do more than they should be doing. So tissue factors we talked about is that, here's a normal muscle on MRI, which is all gray. White is fatty infiltration, and you can see as a muscle starts to waste away or has fatty infiltration, the muscle tendon unit isn't as elastic. It becomes more scarred, and so that's much more fibrous tissue and doesn't have that elasticity, and that also can contribute to high tensile loads at the repair site. So there's been a lot of histological evaluation of what happens if we add tissue to the repair site, because if the tissue of the patient's rotator cuff isn't great, and so one option that's been used is to use a dermis allograft, and we noticed that at 7 months post-implantation, the graft remodels along the lines of stress to help provide mechanical and biologic support to the repaired tendon. And we can see that that's very similar to the normal human tendon collagen pattern. So in my hands today, the state-of-the-art rotator cuff repair really means looking at the patient, looking at their factors, and then trying to maximize these by not only improving the mechanical environment for healing, but also the biologic environment for healing. In my career, probably 80% of the rotator cuff repairs that I've performed have involved some type of graft reinforcement, because we see so many revision, large and massive tears. We know not only from our own work but others that adding this graft more than doubles the healing rate for these large, massive, and complex tears. The graft provides a mechanical load sharing to reduce shear at the repair interface, and then, as we showed in the previous slide, provides a biologic scaffold to help augment compromised native tendon tissue. So here's an MRI of one of our patients, and you can see this is what we're all looking for, is a nicely healed tendon to the tuberosity. Here's where we started off with a massive tear. Here's the end of the repair, where we've done really 2 full repairs. We repair the tissue back, and then we put this graft, so it's a load sharing repair and it's under tension. As I mentioned, several studies have been done. One of the earliest studies that was done was a prospective randomized study by Dr. Barber and his colleagues, and they looked at randomizing patients that had large and massive tears, and they randomized patients. 22 patients got the graft jacket, which is this graft, and 20 in the control arm, and at 24-month follow-up, and they had 85% healing when they used the graft, and only 40% healing in the control. We published a study back in 2012, similarly looking at 14 patients that were all all large, massive, or revision tears, and using our own technique for arthroscopic repair. And we did MRI at all these patients at an average of 16.8 months. And for us, all the repairs were intact, including in D here, you can see this repair goes all the way out, but because we had that small little region, we called that a failure. And so 2 patients in our study were called failures because they had a less than 1 centimeter discontinuity. And even then, we had an 86% healing rate. And you can see, as I mentioned, the strength greatly improved, and that's something that all the studies have shown, that a healed tendon really helps the patient long term, much more so than anything else. So here's just an example of our technique incorporating many of the things we just talked about.
This is a patient with a massive rotator cuff tear and osteoporosis, and we're going to be incorporating most of the things that we talked about, including injectable calcium grafting for bone support of the tuberosity, calcium impregnated triple loaded anchor beyond the footprint, and to maximize the number of sutures for the repair, we utilize 2 perpendicular transosseous tunnels, each with 2 permanent braided sutures. Here we can see different colored sutures through each tunnel that have been passed through the musculotendinous junction of the cuff, and we can also see the fiber tape ripstop suture that we've used and placed the anchor sutures medial to the ripstop suture to help with our repair. Now that we've completed the tension band portion of the repair, we retrieve one of the antramedial and one of the posteromedial transosseous sutures via the anterolateral cannula. These dimensions are measured and transferred to the acellular dermal graft on the back table. Those limbs are weaved through the corresponding medial corners of the graft, and then the lateral limbs pulled, delivering the graft arthroscopically into the subacromial space. Once the graft is delivered, these lateral limbs are tied to each other over the bony bridge, compressing the medial aspect of the graft and rotator cuff footprint. This is followed by passing the remaining lateral limbs through the lateral corners of the graft and tying 2 vertical transosseous mattress sutures, which results in uniform compression of the entire repair and tensioning of the entire graft.
So if we think about reinforcement graft, it's easy to imagine that in that instance where a patient has a rotator cuff that can't be repaired, it's just a natural extension to reconstruct the superior capsule, which is shown here. And here's a superior capsular reconstruction that I performed that the studies show helps bring this ball down. Many of you may have heard of a reverse total shoulder arthroplasty, which is one of the advantages by reversing the glenosphere on the socket side, is that it brings the ball down, and that improves the deltoid moment arm. Well, many of you may not know that in Japan, the reverse total shoulder arthroplasty was not available until 2012. I met Dr. Mihata a couple of years before that, and he talked about that he had done some lab studies and he was using iliotibial band from the patient, folding it up 5, 6, 7 times and using that for the superior capsular reconstruction. And his laboratory studies showed that that helped restore that superior stability by restoring that depressor effect. And so that's where the superior capsular reconstruction was born. And just as a side note, I went to France to train to do the reverse in 2001 in preparation for it being released here in the United States. And probably until 2010, my rates of reverse total shoulder arthroplasty increased every year. Once I started doing the reinforcement graft and the superior capsular reconstruction, it's interesting that there are many patients who really don't have primary arthritis as their symptom generator, and more the loss of depressor effect, and they like the idea that we can do something arthroscopic that preserves their own joint, and then if something happens in the future, we can always switch to a replacement. So this last 10 years, I've really found that the number of superior capsular reconstructions we perform is outpacing the number of totals that we perform. So here's an example of a young man who'd had pretty bad infection. He'd had 8 or 9 operations elsewhere, and was referred to me, and we did a couple of operations. The first operation was to get rid of the infection and make sure everything was good to go. And then, as you can imagine, he really didn't have much rotator cuff left to repair, so we performed a superior capsular reconstruction.
Yep, one more time. And then now, reach up your back. How far up can you go? Yeah.
Some of the newer things that are just coming up, there was a nice article a few years ago that looked at how hyaluronic acid may change the healing environment. And this is something that I think if we can get approved, or maybe something that really helps, because when we do the grafting that we talked about, when we increase the number of stitches to reduce the mechanical load, this doesn't really change the quality of the tissue that forms at that bone-tendon junction. And so one thing we've always known is that when we surgically repair a tendon back, it doesn't have that same footprint, especially that calcified chondroid matrix that exists in the native footprint. And so what's interesting with hyaluronic acid was that it accelerated that tendon to bone healing in the rotator cuff repair model, and also enhanced the strength and tendon maturity, which really is the holy grail. We are on the cusp of hopefully having biologic adjuvants that we can do to really increase that biomechanical strength of the footprint, but also hopefully accelerate that maturation process. So moving on to instability, one thing that I was fortunate in my own training was that I did a fellowship with a gentleman who was one of the fathers of shoulder arthroscopy, and was very entrepreneurial in his creativity in coming up with new devices and techniques. But also he subscribed to this circle concept, which was described by Dr. Warren back in the 80s. And the idea is that the shoulder really is a circle, and you can see here. And so even though many times we think, oh, you have a tear because you dislocated out the front, and that means that the bang cart is all that's responsible for instability, the idea that Dr. Warren put forward is that in the process of coming out the front, you're also stretching the ligaments by nearly 2/3 before they tear. And so instability really, rather than purely anterior, purely posterior, or unidirectional, I've always looked at instability as falling along a continuum. For sure, there is that patient, let's say the athlete who's never had any issue, they get a tackle that traumatically dislocates their shoulder. So that's on one end where it's a pure unidirectional traumatic injury. On the other end is, let's say, the patient with Ehlers-Danlos syndrome, where they have an incredibly elastic tissue that can be injured very easily, and even with activities of daily living, their tissue stretches in multiple directions, and they dislocate in multiple directions. Most people, fortunately, fall somewhere within that range of spectrum. So certainly historically, and when I was going through residency, there were this traumatic, multidirectional, and voluntary classifications, and I tend to minimize this, as much as I look at the spectrum, and then certainly on the voluntary side, the whole idea is that, is there an issue of secondary gain? Is a patient who's learned to certain level of neuromuscular control, using his ability to move the shoulder in and out for secondary gain, whether that's pain medicine or other psychosocial gain. Certainly that can always be a confounding factor. So anatomic sources for instability, we've all talked about the labrum. The labrum is just lip, so we know that in the shoulder, the glenoid is a flat, bony socket, and so what the lip does is really more like a gasket. It helps better match the radius of curvature, also helps with a negative suction effect, and so we talked about it's called different things. So the anterior inferior labrum tear is called a Bankart lesion. There are other names for sure. There's the posterior labrum tear. Superiorly is a SLAP, which is superior labrum anterior posterior. As you can imagine, since the ligaments and capsule are attaching the labrum to the ball or humerus, this can tear anywhere along the course. So a tear at the humeral side is called a Hagel lesion. The glenoid side we talked about. You can also have plastic deformation in trauma, where certain people who have more elastic tissue may stretch this beyond its ability to statically help hold the humeral head centered in the socket. You can certainly have pathologic elasticity, which we alluded to. On the humeral head side, the roundness of the ball can be altered. So for instance, if you dislocate in the anterior inferior aspect, the posterior superior part of your humeral head, sort of like a styrofoam ball, can have a wedge imprint, which is called a Hill-Sachs lesion. If that happens, if you dislocate posteriorly, that's called a reverse Hill-Sachs. Certainly, this can happen in one injury where you have a bony Bankart fracture, but more often what happens is each time you sublux or dislocate, there's some attritional wear and tear and grinding away in erosion of the glenoid. And so we'll see a little bit that we've come to realize that the lower 2/3 of the glenoid really should subtend a full circle. And those patients who are missing part of that circle are at a much higher risk of recurrent instability if that bone loss isn't addressed. Certainly a rotator cuff tear can exist with instability. We see that much more so at age 40 and later. And part of the reason is, as I'm sure you may have all remember from medical school, that we make a different kind of collagen and after about age 27. So that ratio of a primarily elastic collagen to a stiffer collagen really reverses around age 27. So we start to become stiffer with each decade after that. And so that's why we see that with a certain amount of trauma, rather than having elasticity where you're going to have stretching, we start to tear other tissues like the rotator cuff. And so anytime we have a patient who dislocates their shoulder, especially after age 40, we want to make sure that they didn't suffer a rotator cuff tear. So as we said, the traditional arthroscopic technique, which didn't have great results, was really just looking at this one small section of the entire 360-degree area and just doing the Bankart lesion. And this, we'll call this a first-generation technique, and these didn't have nearly as good results as some of the later techniques. So the modern technique really addresses all three zones, A, B, and C. Here we can see a patient that had a 360-degree tear, and you can see we've recreated this bumper cushion and containment all the way around. So for an arthroscopic repair, detecting these lesions preoperatively and distinguishing them from unilateral labral tears can be difficult, and successful treatment requires a high index of suspicion and ability to evaluate and treat pathology in all areas. This is something that we found. We published a study of doing triple labrum tears or 360-degree tears that we repaired with all suture anchors, and that was the first study of its kind with all suture anchors. And so here we can see how important it is for that humeral head to really rest on the cushion and not on the glenoid itself. We talked about bone deficit either on the glenoid or the Hill-Sachs side. And so here you can see, looking down, someone has an inverted pair where they've lost that circle. Same thing, this person's humeral head at the back has been really compromised. And so one thing we can do to address humeral bone loss, so for instance, here's a patient with a large Hill-Sachs lesion. We're able to percutaneously come through the tendon at the very superior and posterior aspect, superior and inferior aspect, and we tie these in a pulley configuration in the subacromial space, and you can see that helps rotate that area of defect extra-articularly and repairs that rotator cuff into the defect. And this is called remplissage, which means fill in French. And this was described by Dr. Wolf, who was my fellowship director. And here's one of our own patients. You can see that that rotator cuff is healed nicely into the defect and has rotated the humeral head so that that won't engage. We talked about bone loss on the glenoid side, and here's an example of addressing that.
This young man is a college quarterback with recurrent shoulder instability, sent to us with the diagnosis of labrum tear, but when we look closely at his MRI, especially on the sagittal best fit circle technique, we see he has quite a bit of bone loss, and it's important to address each contributing factor for instability, including the bone loss. Here at arthroscopy, we can see he has a lot of bone loss, and when we've elevated the labrum completely, we can appreciate this even more. We use non-rigid fixation, shown here, and then all suture anchors placed at the native glenoid to repair the patient's labrum and capsule back anatomically. Here, once the repair has been completed, with the bony support restored utilizing the bone graft, the labrum recreates the bumper cushion and appropriate anatomic height to recenter the humeral head. Here, the completed repair demonstrates excellent recentering of the glenohumeral joint with ample bony and soft tissue support.
So as we mentioned, modern state-of-the-art arthroscopic techniques allow us to not only evaluate but treat all of these sources of instability. And really, to have a high success rate, we need to be able to evaluate and address each of these. So we talked about the first generation techniques, really just doing the Bankart, but that we have to be prepared as surgeons to be able to repair it all the way around, as this isn't always possible to diagnose preoperatively on an MRI. We talked about that the ligaments and capsule can be torn on the humeral side or in the middle or be plastically deformed, so we have to be prepared to pleat or double thickness those where needed. The humeral head, we showed how to address Hill-Sachs lesion with this remplissage rotator cuff repair technique. We talked about how to address bone loss, whether it's in the front or back, and how my personal technique is to use an all-suture raft so that that bone graft gets to remodel under native stress. We also talked about rotator cuff, and that sort of ties in with the original rotator cuff repair techniques we talked about. I appreciate your attention. I hope you found some of what we talked about helpful as you treat your own patients. And as always, I am always open to seeing a second opinion or also historically, I've treated lots of patients who've had previous surgeries and aren't necessarily happy with the outcome and looking for a second opinion. Thanks again for your time.